Hello and welcome to the ADA Time and Range Group's first webinar, Time and Range in the Clinic. My name is Tom Martens and I'll be moderating today's webinar. To share a little bit about myself, I'm a primary care internal medicine physician at Park Nicollet Clinic in Minneapolis, Minnesota, and I split my time between that and working at the International Diabetes Center in Minneapolis, Minnesota, where I work as a medical director and am involved in a range of research studies and translational projects, mostly involving the use of technology in managing type 1 and type 2 diabetes. None of this today would be possible without the guidance of the ADA's Time and Range Advisory Group. We'd like to thank the members for all their hard work in developing today's program. We're also very grateful to the support of Abbott Diabetes Care, who has made this program possible. Let's see who we have joining us today. If you looked at the bottom of your screen, you have two interactive features. You have a chat box and you have a question and answer box. And today we'll be using both those boxes for exactly what they're called. If you want to check in, use the chat box. We can see who's joining us. If you have questions, please put them in the question and answer box, and my role will be to monitor that. We've tried to make this program as open-ended as possible, and we have a lot of room at the end to try to answer questions, have an open discussion, and we're counting on all of you to help us field the right questions. We have a few people joining. Diabetes educator from Waukesha, my home state. Thank you all. It's wonderful to be here. Consider becoming a member of the American Diabetes Association. ADA membership provides opportunities for networking, for growth professionally, and includes a variety of professional member benefits that you can see on the slide. As you can see, you'll have access to a lot of great resources as an ADA professional member. If you want to see what's available, visit professional.diabetes.org/membership for more information. If you look in your chat box, we're going to put the link to that site right in there. Another great resource is the ADA Primary Care Certificate Bundle. It's designed to help clinicians on the front lines of primary care master the latest information from the ADA standards of medical care and diabetes and confidently apply strategies for overcoming therapeutic inertia. It includes the popular Diabetes is Primary and Overcoming Therapeutic Inertia certificate programs and provides up to 22 hours of continuing education credits. You can register for either Diabetes is Primary or Overcoming Therapeutic Inertia programs separately or build your own educational experience by choosing individual modules to register for. To learn more and to register, visit the online programs page using the link on the slide. The Time and Range Group would like to hear from you, so please consider joining the ADA's newest online collaborative, the Time and Range Online Collaborative, to join the discussion. We hope to have tools available to you there, sound bites, podcasts, and so it's going to be a wonderful resource. The more activity we can get, obviously, the more useful it is for all of us. Our agenda for today is addressing time and range in the primary care clinic. The learning objectives are to increase knowledge of time and range, increase our understanding of how to operationalize time and range in the clinical setting, and to identify techniques to help patients understand and use time and range. And so again, we would welcome your questions. Please put them in the question and answer box at the bottom of your screen, and we will go from there. We do have a question regarding whether the Time and Range Collaborative is a new collaborative, and indeed it is. So we hope to get things going, hope to provide a wonderful resource for all of us. Now I'm excited to introduce today's first speaker, Dr. Rozalina McCoy. She brings a unique perspective to our discussion in that she is an associate professor of medicine at the Mayo Clinic in Rochester, Minnesota, where she's a practicing primary care physician, endocrinologist, and medical director of the Mayo Clinic Ambulance Community Paramedic Program. Dr. McCoy is also an NIH and PCORI-funded health services researcher whose work leverages real-world evidence to improve the quality and equity of diabetes care. She's particularly interested in understanding factors that lead to poor glycemic control and heighten the risk of acute and chronic diabetes complications. And she's worked both within and outside the Mayo Clinic to develop patient-centered care delivery models to improve diabetes care and health outcomes. Dr. McCoy has been an active member of the American Diabetes Association and is currently serving as the chair-elect of the Diabetes and Primary Care Interest Group. Dr. McCoy received her undergraduate degree at Harvard, her medical degree at Johns Hopkins, and completed her medical training in internal medicine and endocrinology at the Mayo Clinic, and has been on the faculty there since 2015. So we're excited to have Dr. McCoy presenting on the primary care provider perspective on time and range in the primary care clinic. So welcome, Dr. McCoy.
Thank you so much, Dr. Martin, and to all of you for joining us today to learn more about time and range. And I think how it can really help you take care of patients who are living with diabetes. So like Dr. Martin said, I am a primary care doc, and I think as we manage the complexity of diabetes and all that it entails, I do think that the ability to use continuous glucose monitors and time and range is really helpful to both make it easier for us to care for our patients, easier for our patients to engage with us. And I think ultimately it's a way to deliver more patient-centered care more effectively. So I want to start briefly by just walking you through how I think I got into this and how we use time and range in our primary care clinic. So if you can go to the next slide. So I think we'll kind of talk through 3 pearls and takeaways that I hope you come away with today. I think the first is really to introduce the concepts of the ambulatory glucose profile, or AGP, as well as time and range, or TIR, and show how they are really a patient-centered approach to safe and effective diabetes management during a busy clinic practice, as well as through non-visit care interactions that you may have with your patients, be it by portal, phone, or any other way that you communicate to your patients outside of visits. Because they provide very efficiently with the AGP all in one page, I think, a meaningful and really actionable information about my patients' glucose values to help me make real-time decisions about their care quickly. So if we go to the next slide, I'll kind of walk you through why I think it's helpful. So when I see my patients with diabetes, and I have kind of a combination of general primary care and endocrinology practices, but when you are ready to see patients with diabetes and you need to make insulin or other medication dose adjustments, typically patients come or used to come with a glucometer. The best case scenario as they come with a glucometer is what you see on the next slide, which is their glucose log. And we have to sift through all of their information, trying to make sense of patterns, see what we need to do for their medications, understand patterns. That can take time. And in the real world, our patients often do not bring their logbook. They may not even bring their glucometer. So if they bring their glucometer, we'll be sifting through, information on the glucometer, or have no information at all. And I think that really contributes to therapy, at least for me, to therapeutic inertia. We know that our patient's A1C is high, but we don't have information right there in the office to make any meaningful treatment decisions. And then time passes. Our patients may not be able to follow up with us. We may not have many resources in the clinic to follow up with our patients. So I think that lack of actionable, meaningful information at our fingertips during an appointment is a real barrier to patient care. If you go to the next slide, you'll see this is actually one of my dear patients who's a 74-year-old lady with long-standing type 2 diabetes. Her A1C at this time was 8.2%. She is treated with multiple daily insulin injection therapy. She does have an intermittent scan CGM, and I'll kind of show you how we used it to support her care. Now, she has consistent breakfasts, somewhat consistent lunches, and very inconsistent dinners that are manifest in the complexity, I think, contribute to the complexity of her management. Now, she's a unique patient in that she keeps a meticulous record of her blood sugars and her meals. And every week I get a report of this. And this is what I used to get from my patients who did keep records but did not have a CGM. So usually it's spent a lot of time trying to make sense of, the blood sugars, insulin doses administered, plus the correction administered. And then on the right side, the carbs that were eaten, really trying to find patterns. And every time that she and I would do this, we'd get lost in the weeds. We would find something that was unique in any given day and find it challenging to really come up with a treatment plan and come up with a treatment plan that she would really buy into and want to make permanent insulin adjustments because every day was different. Now, when we got her connected to a continuous glucose monitor, I think everything changed. So if you go to the next slide, I'll show you her AGP. So this is the top slide of her AGP, or ambulatory glucose profile. The top, and it's all in one page and easy for us to see together with my patient. And as we look at this page, we look at this top half of the page. And she has the intermittent scan CGM, but the AGP report is now standardized, and it's meant to be the same for all CGMs to make it easier for us in practice to use them meaningfully with our patients. So the AGP shows the average blood sugars and their trends over a 14-day period. Now, it's very important to teach our patients that the data on the CGM is only as good as the data that they give it. So if they have an intermittent scan continuous glucose monitor, they need to scan their device at least every 8 hours to make sure that all the blood sugar information gets uploaded and gets saved. And that contrasts to the real-time CGM, where it just gets pushed and uploaded no matter what, and you have that information. But for our patients with an intermittent scan, it's very important to make sure that they really do the scanning every 8 hours. So that's definitely right before going to bed and right upon waking up to make sure we capture those nighttime hours. So on the first half of the AGP, sorry, if you can go back, you can see a couple of things that I always point my patient's attention to, and that's this colorful bar graph. The green is the time in range, or TIR, or time that our patients spent in a safe blood sugar range. And that's what I call my patient's attention to, blood sugar 70 to 180. We need that to be greater than 70% of the time. And if you ever forget, it's shown in the gray box just to the left of it. And then we can see in different colors the time that patients spend in level 1 or level 2 hypoglycemia, and then again, level 1 and level 2 hyperglycemia, or low blood sugars, high blood sugars. And I think it's helpful for patients to see in general how much time they're spending everywhere, because the A1C, it's an average. And I know that our patients have really been taught to focus on the A1C, but it's not a helpful indicator of how they are doing, especially for patients on insulin whose blood sugars can vary a lot. Because if their blood sugars are 40 or 400, their A1C may look very nice, but that's not good glycemic control, and that's not safe blood sugar ranges. So we really need to think about what is their blood sugar doing right now. So then the second half of the AGP report that I go through with my patients is shown on the next slide. And here you actually see that glucose profile, and it shows really the 24-hour variation of what happens to their blood sugars over that 14-day period. And that makes it a lot easier for our patients and for us to see trends and make changes to their treatment regimens, because we can see what their blood sugar is on average. That's the dark blue line. Then we know that half of their blood sugars fall in the medium blue shaded region. So between 25 and 75% of their sugar ranges, right, fall in that range. And then again, building out to the light blue range. So we get to see both what their blood sugar is on average and then how much variability there is. So if there's not that much variability, it's harder for our patients and for us to say that this was a fluke reading. And it really is like that. And we can make treatment decisions. So when we look at the AGP, I always tell my patients, you need it to be flat. You don't want it to kind of vary a lot. You need to be narrow without kind of day-to-day variability, and also in range. So flat, narrow, and in range. And that really should be our goal. And then if patients have different schedules day-to-day of the week, that first page also shows you their tracing for that whole 14-day period, so that you can easily see any outliers that you may want to focus in on. So for example, for my patient, looking at this, we would say, I would ask her what happened on that Tuesday when you had a low. Lows are unusual for her. She generally runs high. So we would go and see where's that red dot and focus in on that day. So I think for me, on a busy day with a short appointment, we can use this one pager to really understand how she's been doing over the 14 days, where the challenge areas are, what doses we need to adjust and why, and really get buy-in from our patient because she understands exactly why we're making the decisions that we are. And it can help her also say, well, maybe I should eat differently on this meal, or I always exercise this time. I should, plan for that or measure my blood sugar. So it's really a lot of meaningful information all condensed into one. And it's a lot easier than using a glucometer. Now, if we go to the next page, which is really point number 2. So I think it's very helpful. But I think for when my clinic started doing this, the biggest question is how practical is it? Because continuous glucose monitors have really been in the realm of endocrinology and not in primary care until recently, and mostly with the, I think, intermittent scan CGM. So I think the first thing for us as we're trying to implement it is to understand the requirements for CGM initiation to make sure that our patients can obtain, afford, and then continue to use continuous glucose monitors. And that requires both having the system in our clinic to do it, and ideally also being part of a multidisciplinary team, whether it's with a diabetes educator or a pharmacist to help manage our patients together, because team-based care really is ideal in these situations. So you go to the next slide, really give you a bit of just a high-level overview of the current requirements for CGM coverage. These are the requirements for Medicare or CMS. There is variability for different health plans, but most do follow CMS criteria, though you would want to check with your patient's health plan if there's any differences. But you need to make sure that they have a diagnosis in the claims, and ideally in the note, when you see them for diabetes. They need to be treated with 3 or more administrations of insulin, which is new this year. It used to be injection. Now it's administration to make it easier for our pump patients. As well as our patients who are on NPH-based regimens. We need to make sure that the health plan knows that insulin regimen requires frequent dose adjustments on the basis of blood sugar levels. They need to see a clinician, the prescribing clinician, every 6 months. A common misconception is that it has to be an endocrinologist. It does not. It's the prescribing clinician. So we count in primary care. So they need to start to see us both within 6 months of initiation and then every 6 months of using. The testing frequency requirement for at least 3 times a day testing was removed. So it's a lot easier. That is not there anymore this year, which is fantastic. And one thing that I do, as you see in blue, is that we have in our electronic health record system, we have an ability to do kind of shorthand phrases. So this is my smart phrase to put into my note every time I see a patient with a CGM or when I'm prescribing a CGM. To basically meet all of the prior authorization criteria, because then I can just print and send my note from that day and take care of all those prior auth letters. Because basically you put in everything that they're looking for into one blurb. It's actually bolded as prior authorization specification, and just eliminates a lot of that back and forth and paperwork. And I do similar things for medications too, in case you have trouble with prior auths. So next slide. And then finally, I think for our clinic, using CGM in just routine practice wouldn't be possible without a multidisciplinary team. We got started because we have really an incredible pharmacist who's part of our team. We do have certified diabetes care and education specialists as part of our broader healthcare system and our primary care team, but they're not located specifically in our clinic where I'm at. But we do have a pharmacist who focuses on diabetes management, and with his help, we were able to set up the Libre Viewer account for intermittent scan CGM, connect our patients to it, and kind of keep track of their blood sugars both when they're home and in the clinic. So I think partnering with a CDCES really is critical. They can dive in deeper into the CGM report, provide technology support, helping our patients get connected and stay connected, deliver education, improve awareness of hypoglycemia for our patients who struggle with hypoglycemia unawareness, and help with insulin dose adjustments. So I want to turn it over now to Stacey, who's going to offer her perspective as a CDCES working with patients using CGM.
Thank you so much, Dr. McCoy. That was a wonderful presentation. Just want to remind you that if you have questions that are coming up, please put them into the question and answer box at the bottom of your screen, because we will have time at the end of our presentations to hopefully go over the questions, have a little bit of open-ended discussion, and hopefully answer the questions. So at this point, it's my privilege to introduce our second speaker, Stacey Cooney, who will be providing her perspective on the diabetes educator role in addressing time and range in the clinic. Stacey A. Connolly is an experienced CDCES certified diabetes educator at the Joslin Diabetes Center in Boston. She leads the technology team, which educates and assists patients and staff in using continuous glucose monitors and insulin pump therapy. She has also developed curricula for education in the use of continuous glucose monitoring for professionals and patients, and she provides direct patient care and education to both individuals with type 1 diabetes and type 2 diabetes. Prior to working at Joslin, she spent many summers working at diabetes camps, which grew her passion for the young adult population with type 1 diabetes, where she specializes in the transition from pediatric to adult care. Stacey is a graduate of Curry College with a Master of Science degree in nursing. So we're excited to have Ms. Connolly with us today to share her experience. Welcome, Stacey.
Thank you both, and thank you for the opportunity to speak on the educator perspective here. I feel like if you want to advance the slide, I believe that successful use with CGM starts at that initial training. As you train the patient and educating them on just the basics of CGM use, understanding the difference between interstitial fluid versus capillary glucose, sensor lag, and calibration. Other topics that we discuss with the patient are going to be about, setting the high and low alerts, the rise and fall rates. I feel it's important to find a balance between those because if you set maybe the alerts to the ranges too narrow, the patient can get over alerted. If you set them too wide, the patient may not get any alerts at all. I think it also brings the opportunity to discuss what the patient's glucose target ranges are as you're setting those alerts. During the initial visit, we also start to talk about and access reports and what time and range is introduced. The educator also offers support with coping and problem solving with new technology and concepts. I was asked to describe how I actually talk about time and range with our patients, and I feel like it's the easiest way to go with it, or the first step I say is I talk about the A1C. I say to the patient, you know what your A1C is, right? It's that average glucose, and then I go from there and say, well, time and range is more about how you get that day-to-day variability. It offers a much bigger picture of the day-to-day management. And this comparison usually hits home for patients. They can usually kind of start to identify that and think about it. I also try to provide education around the meaning of what the time and range means, and then define those standard target ranges of 70 to 180 when appropriate appropriate, because as we know, maybe that is not for all populations, those may not be the standard. I feel like while discussing time and range goals, it can also help you and your patients establish their goals for time and range. If you can advance the slide. I love this example. As we can see, CGM reports can identify glucose patterns and variability. They assist patients in that deeper dive examination, which can also reveal additional educational needs. In this patient example, as we can see, or as we know, patients can see more hyperglycemia. Well, that information is helpful. A very common response to that is to take more insulin, resulting in hypoglycemia. As we do report analysis, it really allows the provider and the educator to identify behaviors and set and see the percentage of time and range and the percentage of hypo and hyperglycemia events. Often, this can lead to an open discussion of what the patient does think may be the cause of either the hypos or the hypers. Is it a behavior that they need to change, or is it an insulin dosing that they may need to change? So additionally, you have the chance to re-educate patients on insulin action, the timing of that. Are they pre-meal bolusing? Are they post-meal bolusing? Is that causing highs and lows? The food complexities that we see, because, as we have patients carb count or take insulin for that, but, sometimes food isn't always as straightforward as we would like it to be. Exercise, then looking at insulin on board. And again, all of these things, you're educating them to try to have them increase their time, their time and range. I also think it's important to try to focus on what works with the patient as you're looking at different reports, and that may be a multitude of the reports, but take, for example, the daily view. If you see a day where they're spending most of their time in range, asking the patient, hey, what did you do this day that was different from maybe another day? And how can we replicate that? I think you need to also remind the person with diabetes that to aim for improvement, not perfection. This was definitely a tagline that one of our former colleagues from Joslin used to say. If you can advance the next slide. This actually comes from the Association of Diabetes Care and Education Specialists. It's a way for the certified diabetes educator to work with the patient in terms of looking at the data. So you can see data download, they're assessing safety, that time and range, areas to improve, and then of course an action plan. If you can advance to the next slide. I think some of those take-home messages are encourage the use of a CGM, encourage the use of CGM when possible, ensure that the patient has proper training and ongoing education when using CGM technology. You need to have a continued review of alert settings and patient response, review and analyze that data with the patient, help identify trends for behavior change, and ensure that the patient has realistic expectations. And as I previously mentioned, really trying to drive home that you're aiming for improvement, not perfection. And that's it for me.
Thank you so much. Those were great presentations provided by both our speakers. I know as the speakers were working to put today's program together, a key goal was to make this as interactive and real as possible. And so we've reserved a lot of time at the end for questions. So again, if you have questions, put them into the chat box. We have some wonderful questions already, I can tell you, and we will see if we can work through them and have a little bit of dialogue and discussion. So if I can launch with the first one, and I think either of you can take this on. Let me just see if I can make my screen a little bigger here. So we've been talking, if you look at CGM data in general, you have two types. You have real-time data Person can see exactly what their blood sugar is anytime they want to. And you have retrospective data, and we've been talking mostly about retrospective data. So we have a question regarding whether there's an application or website in which you can enter a patient's information to give the time and range diagram, which is to say, and this can be for Dr. McCoy, and I think Stacey's answer will probably be a little different. How are we accessing retrospective data with these devices?
Yes, I can share kind of what we're doing in our clinic. In our primary care practice, we primarily focus on patients who have intermittent scan CGM. So because that's the majority of patients who have type 2 diabetes who are managed in primary care, use IS-CGM versus real-time CGM. So we did sign up for the LibreView account, which is what Freestyle Libre comes with. We set it up for our whole clinic. So when we have patients who do get the Libre, we kind of invite them to join our clinic's team so that they can upload information that we see in clinic, whether they're in the appointment or not, or they bring the device with them and we upload it during the rooming process. And then during the appointment, or when I'm taking care of them by portal or phone, I can see that information and get it easier. There's similar things you can do with the real-time CGMs. We don't use them yet in our primary care practice. We're working towards it, but it's a bit more complex, and every device has its own cord and cable and software, which makes it, I think, harder for primary care practices. So I think if you're just starting out, I would really look at your patient population and where you want to start with for the clinicians. But ideally, you'd have an educator, and I think they'll know all the nuances of what to do for all your different patients. But I think that's really critical to be able to access that information.
I'll bet you Stacey has a very sophisticated setup for accessing these cloud-based data for retrospective CGM review.
We actually have a lot of the same as Dr. McCoy was saying. We have the opportunity to use LibreView, Dexcom Clarity, CareLink for patients. We strongly encourage the patients to be able to upload their data. Now, with the pandemic, that has become a little bit different. And I mean different in the fact that it's more strongly encouraged. So we're linking a lot of people to be able to share their data with us, because in the remote world, you can't come in and drop your CGM off at the desk for someone to, upload that for you, where a lot of our patients were, I think, kind of used to that. So we do use all of those same websites and are getting people linked and connected in the right way.
Yeah, I know in my practice, we really lean in on our diabetes educators for startup, essentially, because people really, it's pretty intuitive. You can go on these industry websites, you can watch videos, and you can have a CGM in place and on your telephone very easily. But I think what I've observed is that there's a huge role for diabetes education to help people understand time and range goals, help people understand what to do with the data they're seeing and how to really use it to improve safety and improve the management. But I know one barrier that a lot of practices have, I'm a little fortunate to have diabetes education right in my clinic. What do we do if somebody doesn't have access to diabetes education for startup of the device, for helping to get hooked up to these industry clouds, and for teaching?
So, I think I can start off. So we don't have, unfortunately, an educator right in our clinic. We're thankfully able to refer patients to an educator when we need to. But we've leveraged our clinical pharmacist a lot. I know many places don't have pharmacists either. I think pharmacists are fantastic because I think they're easier sometimes to get because or to justify, because they serve so many needs for a variety of chronic conditions. So they can help support diabetes as well as other things. So I think pharmacists can serve that role as well. You can get a lot of really helpful, I think, information from websites. There's YouTube videos, just make sure they're reputable. I know ADA makes a lot of information as well, both for patients and for clinicians. So there's a large repository of materials that can be used as references. And we actually to get our patients started, we have, again, like a smart phrase prepared that we send for how to patients to sign up for LibreView and get connected. And that was actually prepared by one of our patients who did it and then shared it back with us, and we are using it. So that's been fantastic because it really is an easy kind of walkthrough guide. I think it's hard the first few patients you set up because you don't have the system established. But I think even our care team nurses now are very good at using, at least with the Libre, and getting our patients set up, connected. Even local pharmacists at the community pharmacy can help patients get set up. So I think there's a lot of knowledge about this. We just have to ask.
Wonderful. So here's a question. This is a practical question, a very useful mnemonic in helping to think about time and range goals is more green, less red, which is to say, if you're looking at that stacked bar graph, you want more green, you want your green to be greater than 70%, and less red, which is the hypoglycemia range. You want that less than 4%. So the question is, our printer only prints in black and white. Can you suggest anything to help highlight this concept and really help people use data in a functional way and intuitive way?
I pull it up on the computer. We have the same thing. Our printers are all black and white. So I just pull it up in the office and show it to my patients. And I think it becomes, and then I kind of use my hand. I use my hands a lot, so that tends to also help. But yeah, I agree. The stoplight definitely helps drive it across. And then I do talk to my patients about the flat, narrow, and in range. For them to be able to see it on the actual profile, because when they see the rapid swings, I think they intrinsically understand that it's not safe to be going, roller coastering your day, and that's something we should avoid.
So here's a glycemic metrics question. What's the recommended % variability on an AGP report? And so it's an interesting question because it raises the whole topic of variability, because unlike Fingerstick blood glucose monitoring, you're seeing people go up, you're seeing people go down. I mean, the target for variability is less than 36%. But what do we do when we have these folks who are all over the board? And it really is highlighted by this data. How can we help them to improve their management?
Actually, would love to hear Stacey's thoughts on that, but I can jump in afterwards, hear what the experts.
Yeah, that's great. I think that's a great question. And I just actually wanted to go back to the person's question about if you're printing in black and white. We do a lot of the same thing that, I pull my screen up, and if I'm in the office with the patient, I can share that, but I can even share that data on the screen with them, virtually as well. So I often do that. So, because it also, I think, brings home, because you can kind of start to talk about the reports and point out the important pieces that we look at, but that they should be looking at, looking at as well. As far as the question is about helping with glycemic variability, and yeah, I mean, that I think goes back to, as an educator and as a provider, helping the patient identify trends. How often is it happening? Getting that percentage. Is it a trend? Is it something that, if it is that trend, is it something that is, that fixable? Sometimes I feel like patients may get a little more focused on we'll call them the random lows or the random highs, and they focus in on that versus the actual pattern. And I'm not sure that completely answer the question, but I kind of take it from that angle of really looking at, okay, what are we seeing here? We need to focus on, like anything, even in fingerstick management, we always try to focus on the lows first. You continue to do that with with CGM as well.
Yeah, and to add to that, one thing that I do is, that's another reason why I really like the AGP. I know I keep coming back to it, but it also shows us, it helps us by looking at the overall, the 14-day trend. You're going to get away from those one-offs and help focus on the patterns. And, with the great variability, it often comes to, I think, three things, especially for our patients on MDI therapy, that I talk to them about. But we talk about when do they bolus, because often the rapid rise and fall, it's for patients who bolus after meals. So they go high and then they plummet. Patients who overreact to everything. So if they're high, especially postprandial, and then they overtreat that, and then they have a low, then they overtreat that, and they become into a cycle of highs and lows. So I think working on patience and the rule of 15 for treating lows, and I think being a little bit more tolerant of postprandial highs so that you don't have a low. So I think that is helpful. And then the other is seeing if it's a particular meal, what patients are eating. I have one patient who had horrible variability, always in the morning, first thing in the morning. Nothing we did seemed to work until we realized she was buying this fancy coffee drink with probably the most sugar imaginable to humanity. And as soon as we substituted that one drink, problem disappeared. So I think really knowing what your patients are doing is very important. And that's why seeing those patterns, I think, is so much more helpful than just the snapshots of blood sugar readings.
Yep, wonderful answers. No, I know when I see individuals with very high variability, I start to think about timing, obviously, as you guys have pointed out, and barriers. Is there a cost of insulin barrier? Is there something that's causing people to miss doses? And I also think about, is this a perfect candidate for a diabetes education consult? Because I can tell you our diabetes educators are expert at working through troubleshooting.
Mm-hmm.
So here's one. What is your approach? And I think either of you can take this on. What is your approach for adjusting time and range targets in older patients and those with higher risk of hypoglycemia, perhaps higher risk of hypoglycemia than hyperglycemia? How do we adjust our targets for modified goals?
So I know for the intermittent scan CGM, it's kind of embedded. So I think the pictures is what you get. Practically speaking, I do have a higher lower threshold for my patients who are at risk for hypoglycemia, as well as patients who have different glycemic targets because of limited life expectancy or complexity of regimen. So you kind of go up even 100 to 180 or even 120 to 180, depending on where they are. I think the biggest thing to realize is that we're not adjusting targets because we are ourselves unable to modify their regimens well enough and we're just giving up. So I think you still have to make sure that we're trying to get our patients to be in a safe range rather than just modifying the targets, because you do have, if they're having hypoglycemia, changing the target alone won't solve the problem, right? You have to change their regimen. But I do think it's important for our patients, especially with an impaired awareness of hypoglycemia or frequent hypoglycemia, to at least strive to be closer to that 100, above 100. I don't know what Stacey, what are your thoughts are?
Yeah, I tend to, I think for those patients that have hypoglycemia unawareness, just trying to set that threshold on that alert or that alarm is helpful, usually around 90, so that they can catch it earlier.
And I guess I'd point out it's helpful to keep in mind that these international consensus goals from 2019 actually include some modified targets for individuals who are at higher risk for hypoglycemia, who have limited life expectancy. And so for that group, the time and range target goal would be not greater than 70%, but greater than 50%. And for those folks who are at higher risk for hypoglycemia, the hypoglycemia goal is less than 1%, not less than 4%. So there are some standards that can guide us also. So here's an interesting one. And let me tell you, do I ever see this in clinic? If there's a discrepancy between laboratory A1C and CGM A1C, which one do you follow?
My personal peeve, and those who work with me know this, I don't like the A1C because, again, I think it's an average that overlooks reality sometimes, especially, again, for our patients with high variability. because we don't care about the average. We care about how patients are actually doing. And to me, it's their actual blood glucose levels. So I look at the time and range and I look at that AGP. I don't usually look at the GMI, the glucose management indicator, which is like the calculated version of A1C. For the lady that I showed you, I was just looking at her report. Her GMI was 6.9. Same time her A1C was measured, it was 8.2. And that's because she is neither flat, narrow, or in range. And that's why. So we really care about having their blood sugars in a safe range, at least for me.
I feel like I probably focus a little bit on both, looking at that time in range. And I'll bring it back to the remote world, that GMI, because some patients haven't been able to come in for their labs. So having that information at least gives a little bit of a guide in terms of where they may or may not be, where they may or may not be going, and explaining to the patient this isn't an exact GMI, it's an estimation that when you go to the lab, it may not always be the same. Because I think for a while when we were talking about that GMI and patients would have their labs and their A1C didn't come back exactly the same, they would somewhat get frustrated and be like, yeah, but the GMI said this and my A1C is this. So just again having that conversation of this is what this means. This is what it's not going to be exact, but again, it's giving you a little bit of that guidance in terms of, hey, you're 8.2. We know that you want to be 7 or less. What do we need to look at? What do we need to focus on to make those changes to get that, not only to get really that time and range up.
Yeah, and we have to realize, right, A1C is not perfect, right? It is affected by red blood cell turnover, by various anemias, by illness, by chronic kidney disease. Even there's variability by just hemoglobinopathies and different racial and ethnic groups. So it's not a perfect measure. It's a surrogate. It used to be the best we had, but I think now we just have better.
Well, and it's certainly more timely. It's a surrogate. It's also very time limited. It's a 3-month average. And you're right, impacted by all sorts of things. Whereas the time and range is something that's much less time averaged and much more actionable in the short term. And so it really, maybe that's the tool that we use to improve our A1C measures. Here in Minnesota, Dr. McCoy and myself are measured by our A1C measures, and it's publicly reported. So in primary care, it gets a lot of attention, but I think time and range may be a much better tool, especially for folks on insulin, to help get us where we need to be. Okay, so here's a question for Stacey. Really like the successful patient caregive use. Those are great chunks of information. How long does it take you to do the 6 steps you outlined on average?
So a typical training where you're kind of going over the insertion of the sensor, setting the target goals is usually about 60 minutes. That's how we usually book or schedule those patients. For the older adult over the age of 65, that appointment might be slightly longer at 90 minutes. And then we usually try to have a follow-up 2 to 4 weeks after they start CGM. And that, in part of that follow-up, it's going through, how are you doing with everything? What's your response? And then taking that deeper dive into the reports.
Perfect. Okay, so here's a technological question regarding specifically intermittently scanned sensors. How frequently do you need to scan intermittently scanned sensors to capture all the data? How long can those sensors hold on to their data?
8 hours, right, Stacey? I'm not crazy. Okay.
8 hours
Yep.
It is.
Yep, you're not crazy. 8 hours.
So if you go beyond 8 hours, what you lose is the data that's at the front end of your data set. So if you sleep for 10 hours because it's the weekend, you lost 2 hours at midnight or something like that. Mm-hmm. I know what I tell my people is go ahead and scan as often as possible, before meals, after meals, you get real-time data. You can see the trend arrows, whether your glucose is going up or going down. And in addition to that, you're transferring data from the sensor to the reader or telephone. So you're saving all that data for retrospective use.
Yeah, if I can jump on that arrow thing, I think that is incredibly powerful and helpful because I think, for many of my patients, especially if you can imagine a situation at bedtime, they measure their blood sugar and it's 100. It really matters whether it's a flat 100 going up, or rapidly going down 100. And I think it really prevents a lot of that overreaction and overtreatment that can spiral into that cycle of lows and highs in the roller coaster if we know what that point in time is actually doing and where it's going. Also encourages our patients to test more frequently, potentially, if the arrow is pointing up or down, and know when to test. But I think it really our bodies aren't a static thing. We are changing. So I think having that directionality and that arrow is incredibly helpful, and a great safety tool too.
I would add to that, yes, having, as we think about the arrows, I feel like that comes further down the education road. I feel like patients need to get used to just the overall use of it, and then you get into a further discussion about the arrows. And I often give the example of it, to your point about safety. If you saw two arrows going down and you were about to go drive, you might not want to get in your car. You're going to want to confirm that glucose with a finger stick and treat so that you're not driving.
Perfect. Yeah, trend arrows, very useful for sure. So I have 2 questions about correction dosing. So maybe we can send this one Stacey's way. What do you say to patients who check their fingerstick blood glucose and intermittent scan CGMs before injection correction dosing? What reading do you recommend? Some of my patients just don't want to trust the CGM data.
Yeah, and for a patient like that, I think it's really okay. It's really okay to say, we were always kind of taught that the finger stick leads as opposed to the CGM. And certainly then there's always that conversation of if how you feel doesn't match a finger stick reading, you're checking. But if there's a certain level of comfort and the patient wants to do a finger stick, by all means. And you have to also remember that some of the devices are not FDA approved to make insulin adjustments off of the data. So patients have to be, you as the provider have to be mindful of that.
Yeah, and I think the one thing that helps, especially from early on when my patients may not trust the CGM because of that discrepancy, it helps to preempt it by explaining that we do expect the numbers to be different because they are measuring a different glucose level. It's a different compartment. So not only is there lag time as the glucose equilibrates into the interstitial space, it's a different glucose. And if you go through like the cycle of blood from the heart to your organs and then back to the lungs, and they're giving up oxygen, and where you expect there to be less oxygen and less glucose. So when you go through and you kind of say you expect it to be low, and you said that like different, and the fact that every FDA approved device is going to have intrinsic variability, and it's still fine. You can poke 2 fingers and they can vary 20 milligrams per deciliter, and that's fine. And so I think setting that expectation up front prevents our patients from losing trust in a new device because they expect it to be different. And in reality, because of that variability, you tell them the truth is somewhere in between. How you feel is important, except if you're unaware of your hypoglycemia, and then you go with whatever is the safest for you. But again, it's setting that expectation so people don't lose trust is important, I think.
Perfect. Love it. So last question, we're running out of time. A recent publication has highlighted the differences between GMI, glucose management indicator, and A1C. How do you explain this in your patients where the GMI based on the glycemic metrics says one thing, the A1C sometimes is considerably different?
I think for me, it's similar to what we already mentioned. tell them I don't like the A1C. But you kind of go through that the A1C is affected by other things. It's a lag time. You know, this one calculates 14 days. The A1C is 3 months or different depending on your red blood cells. So I think more explaining of what it means rather than to my patients, I don't necessarily discount the A1C, but we just kind of talk through about what they are, what they're measuring, and what each piece of information tells us, and what it means, and why do we care? I mean, and that's meaning the association with clinical outcomes like complications.
I would say that I generally describe it the same way, and I always kind of also say that, at least for right now, the A1C hasn't gone away. Could that be what the future is going to bring us? It's probably up for discussion and at a much higher level. But just trying to, I think, focus on the time and range, but then also, the focus on the A1C, because that's still a metric that we use.
Right. And there's a time and place for everything. I think the A1C is useful and reliable in patients in whom you do not expect a lot of variability. So patients who are not treated with insulin, or even patients on sulfonylureas, they could have lows, but usually the A1C is more reliable. I think it's really patients on intensive insulin therapy with a lot of variability in whom I don't rely on the A1C. For other patients without great variability, I think it is still a useful tool.
Perfect. So I think it is time to wrap up today's webinar. I'd like to thank both our presenters, Stacey and Rozalina. Wonderful presentations, useful information. I'd also like to thank Abbott Diabetes Care for their support of today's program, and obviously each of you for joining us today in this discussion. The Time and Range Initiative is a new initiative from the American Diabetes Association, and we plan to launch additional resources. So be on the lookout for upcoming webinars. We have some podcast episodes, some practice pearls that hopefully will further highlight some of the things we discussed today. At the end of this webinar, you'll be asked to complete a brief survey. Please provide us feedback because we would like to build on what we've done. And thank you again for your time. We look forward to connecting with you at the next Time and Range webinar.